Hello, everyone. My name is Stavroula Savelidis, and I am the Executive Director of the Nassau County Medical Society and the Nassau Academy of Medicine. Thank you all for joining us today for our webinar on COVID-19. Before we start the presentation, I just wanted to review some housekeeping first, and then give the floor to MSNY Membership Chair and Nassau County Medical Society Board Member, Dr. David Podwall, to say a few words. And then our Nassau County Academy of Medicine President, Dr. Moody, will introduce our speaker. So, housekeeping, this webinar will be recorded and it will be made available to listen to after the event. We will be muting everyone while our speaker is presenting, and at the end of the presentation, we'll unmute for a brief Q&A. If you have any questions during the presentation, feel free to initiate a private chat and I'll respond accordingly. Dr. Podwall, you have the floor.
Thank you, Stav, and thank everyone for joining, and thanking Dr. Hirschwork for providing this important update. I think as physicians who all have been under tremendous stress and pressure, whether it's in your offices trying to keep things afloat or working in the hospital in the front line and putting your own personal health at risk, it's important when we're working as hard as possible to know that your medical society, that's the Medical Society of the State of New York and the Nassau County Medical Society, are trying to work as hard as possible to assist you. And we have seen some benefits in that. In working with the New York delegation, congressional delegation, AMA, we had a lot of good things happen with Medicare, including the CARES Act that provided a lot of grant money to physicians' practices. One tranche went out, the second one is now being done. And also the Medicare Advanced Payment Program that was helpful for many practices. We also got Medicare filing to allow telemedicine outside of rural areas, which has allowed our practices to continue to function. In the state of New York, the medical societies had similar things. We went immediately to the Department of Financial Services saying we gotta allow telemedicine, and the state required it. And when they required it and they really weren't doing it in the beginning, and I'm in a private practice and we had companies say, well, we're not ready to do it. We spoke to the governor's office and state senators, and they put pressure on them and they found a way to do it. And they have been doing it. And now requiring also that phone calls, at least for Medicare, going back to the state, federal level, is now being paid at the same level as the virtual call. So we've had success. We still have challenges in working with the insurance companies. Some of them are now providing advanced payment programs to primary care physicians, United and Empire. We're going to work and try to get others to do the same. We've been working hard on issues like the PPE, which initially has been an issue for all healthcare providers. We got the state to agree to give through the Office of Emergency Management, so each county, and they've been giving out supplies, though that is somewhat limited. And the MSNY itself has been able to get surgical PPE and masks, N95s, that members of the medical society are able to buy at cost from us. So these are some of the measures we've been taking and trying to push both the federal and us on the local level to assist physicians in this time. And I think it's important that there's a time if we're ever going to need organized medicine and need people advocating for us, this is it, because a lot of big decisions are being made. In the midst of all this, we passed the New York State budget, and initially that budget included that doctors had to pay for half of that excess layer of liability that we get on top of our regular malpractice. We fought back and said, this is absurd. When physicians are being asked to do all this for the community, you're now going to make us pay more for our malpractice. They agreed, and they took it out of the budget, and now we're not paying for that at all. The state pays for that excess layer completely. So we've had some successes. We still have challenges, but the medical society will continue to work, and we encourage you to reach out to us, reach out to Stav, at our executive at Nassau County about problems and issues you have, and we will try to find the resources or solve the problems that you're having. That's our role, and we're happy to do it, and we appreciate your membership as part of the society. And with that, I believe I'll give it back to you, Stav.
Yes, Dr. Moody will take the floor to introduce our speaker. Thank you.
Thanks, David, for providing all that information about what the Society is doing. And now, Dr. David Hirschwerk is the Executive Vice Chairman of Clinical Operations in the Department of Medicine at North Shore University Hospital, Manhasset, in the Long Island Jewish Medical System. He's Assistant Professor at the Zucker School of Medicine at Hofstra in Northwell. He's an extremely active clinician in the Division of Infectious Disease, where he specializes in the care of patients with compromised immune systems, including those who have undergone solid organ transplantation, received cancer treatments such as chemotherapy, and those who are living with HIV. Dr. Hirschwerk has a leading role in several quality and patient safety initiatives in the Northwell Health System. He chairs the Committee on Infection Control at Glen Cove Hospital, is a member of the Infection Control Committee at North Shore and Manhasset, and he's a member of the Antimicrobial Stewardship Task Force within the entire Northwell Health System. He's a highly sought after educator by residents, fellows, and medical students within Northwell Health. He lectures at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell, and he serves as the chair of the Student Advancement Committee for the medical school. Most recently, Dr. Hirschwerk has been instrumental in Northwell Health's response to COVID-19. In addition to working tirelessly as a clinician on the front lines treating COVID-19 patients, he's spearheaded various operational and research initiatives in combating COVID-19. I thank Dr. Hirschwerk for his extraordinary work and welcome him this evening to share his recent experiences and insight on our ongoing battle with COVID-19. Is there sound?
I think Dr. Hirschwork is muted. Unmute. Dr. Hirschwork?
Yep. Can you hear me?
Yes.
Okay.
Now.
I lost the I'm sorry, everybody, but can you bring the presentation back up? I can't see the I can't see the slides.
Okay. Let me just.
Oh, I think I see it now.
You got it?
Yeah. And how am I advancing these slides? I
am going to give you remote control
okay.
access. One sec.
Thank you.
Okay, you have control.
Okay. Okay, let's see. Bear with me, everyone. Just
okay, that's you moving the mouse, so.
Right.
There you go.
Okay. Okay. So, well, first of all, thank you, Carol, and thank you, David, and Stav, and everybody for joining. And I think it has been a very long few months for everybody. And I thought what I would do is give a background briefly on coronavirus, because I feel as though most of us have become more expert in this area than we ever dreamed or cared to become. And I thought I would also give a bit of a glimpse of what has been happening within the hospital and some reflections moving forward as we are coming out of this really difficult time, and as we also have to think to the future and some steps along the way that I think we'll have to go through. So as we all know, the coronavirus is related to both SARS and to MERS, in that these were all coronaviruses, and this COVID-19 virus, which is a coronavirus, was identified at the end of December, early December, at the end of 2019 in China, and has spread globally since then to become the pandemic that it is. Predominantly spread by respiratory droplets, but we'll get into a little bit more of the other ways in which we believe that it spreads. But I will say that despite the fact that there are other ways in which this virus spreads, that the main way for spread remains close contact with other individuals. So spending more than spending more than 10 minutes with somebody who's infected, whether they are symptomatic or not, and the more prolonged the exposure, the greater the risk, and the higher the viral amount of the infected individual, the greater the risk. And, you know, we'll go through some of that in a little bit more detail. But it is a zoonotic RNA virus. So this is a virus that can spread from animals to humans. And coronavirus, as we have known it in our communities, really was a cause of the common cold, except that there were other strains that existed, both SARS and MERS. SARS, interestingly, just kind of disappeared on its own. And while there was great concern for what it may have done, really within a few months, it was gone and never came back. And it's still a little bit of a mystery as to what happened with SARS. MERS continues to circulate at very low levels, but has not become nearly the problem that COVID-19 has become. The main clinical signs and symptoms include fever, cough, and shortness of breath as the illness progresses, with GI symptoms occurring in about 5 to 6% of individuals. More severe symptoms include respiratory failure, acute kidney injury. It's also been common for people to lose their sense of smell, sense of taste, and that has been an expansion of the type of clinical symptoms that people are aware of. Initially, it was recognized that it really presented similarly to influenza, except that the difference between this virus and influenza is that while there are fevers, body aches, general malaise, and cough with it, that COVID more commonly presented with a dry cough, and then it often presented with shortness of breath as well. And even in patients that had very minimal symptoms, shortness of breath was a common complaint that patients had, and that's less common with influenza. Fortunately, we started to see more and more COVID as the influenza season was ending. We had some overlap initially in the early and middle part of March, but then influenza almost abruptly stopped, and really virtually all of our respiratory illnesses that we were seeing were caused by COVID-19. So people can be exposed, and then the incubation period is anywhere between around 2 to 14 days. Patients present with cough, shortness of breath, but other symptoms, as I said, include headache, sore throat, and new loss of taste or smell. This was an expansion of the initial clinical definition for COVID-19. And once these added symptoms were put into place, it also triggered the recommendation to increase testing in groups of individuals who had some of these other symptoms. In the early stages of our pandemic, frankly, we just did not have enough testing available. We're at a very different stage now, and we have been for many weeks, and there's a very low threshold to do testing, number one. And number two, I think that what you're going to see is really a push to do more and more testing, even for minimally symptomatic people, because the only way to sort of get us through this in the next few weeks, months, and potentially years until there's a vaccine is for us to do more and more testing, identify individuals who are infected, and to mitigate those situations. And we'll get more into that as we go forward. So the spread of the virus, again, predominantly is a droplet spread. And what that means is that the virus lives on larger respiratory droplets that generally travel only around 3 to 6 feet. And these larger droplets are quote unquote heavier, and people can become infected if they're near somebody who is coughing or sneezing or speaking loudly, which has been another recently described way in which the virus is delivered to the environment more than people who speak softly, which is interesting. And then those viral particles don't really travel beyond 6 feet. I would say that's probably true for about 70 to 80% of the way in which people become infected. And that was what initially, very early on, led to the World Health Organization recommending the use of surgical masks as the main type of protectant. But it soon became recognized that it was more than just droplet spread, that this virus had the ability to live in very small droplets that can remain in the environment for a much longer period of time, and leading to what we know as airborne spread, for which we know that we should be using N95 masks for. And in the same way that tuberculosis or the measles virus can live in droplet nuclei, very small droplet nuclei that can remain in the environment for a very long period of time, that, at least in a small percentage of cases, is how we believe that many individuals do become infected with COVID-19. So this slide is from a little bit over a month ago, and really what I just want you to see is something that you're all experiencing, and I think you've all seen very much already, that the New York area and the area of Nassau County and Queens and Manhattan and the Bronx and Brooklyn really is the epicenter for COVID-19. There is no other part of the country, and really there's no other part of the world that is as heavily affected. At its peak in New York State, we were seeing 9,000 to 10,000 cases a day in New York State, predominantly in the downstate region. Currently, we're down to, in the last few days, about 2,000 cases a day in New York State. Still a lot of cases every day, but far from where we were at its peak in the early to middle part of April. So a couple of just numbers, and then I'll get into some other things. So, and these are kind of some interesting numbers, but worth knowing that of all of the individuals who become infected with COVID, and I don't just mean infected, I mean infected and tested, because there's lots of people who never got tested, either because they thought that they just had some mild respiratory illness, or because they were completely asymptomatic, or because testing was just so impossible to obtain in the early period in March. But that aside, for 80% of people who were diagnosed, they remain home. So 20% are hospitalized, 5% require ventilators, 1 to 4% mortality, although I think that we're finding that it's actually closer to 6 to 7% mortality. 80% of the individuals had a prolonged close exposure to a known case, and 20% really had minimal exposure, which is when it really started to be recognized that asymptomatic spread was a way in which this virus was transmitted. So in February, even before there were really any cases in our region, and just about the time that we started to see some cases on the West Coast, this was a series that I've summarized here that was published in the New England Journal of Medicine of over 1,000 patients that were diagnosed with COVID-19, the mean age of 47 years old. And this really was an illness that seemed to affect men more than women. Of the cohort that was published in this series from China, 5% of patients were admitted to the intensive care unit. The mortality rate was reported to be lower, though there is some question as to whether it is in fact this low. Fever, though only 43% on admission, was very common during the hospitalization. 2/3 of patients have a cough, mostly a dry cough, myalgias, sore throat, and diarrhea in a smaller percent of individuals. And the median incubation period was around 4 days. Interestingly, the CAT scan of the chest when performed showed an abnormality very commonly, and even in the individuals with very minimal clinical symptoms, if they had a CAT scan of the chest performed, they very often had ground glass opacities. I can't tell you in the early stages of this how many CAT scans of the chest we were seeing, all looking almost identical, with diffuse, bilateral ground glass opacities, in some cases very minimal opacities, but almost always present in these patients. And the other clinical finding that was seen quite commonly was lymphocytopenia in over 80% of patients admitted to the hospital. So this was a large series from China, and soon after the pandemic really hit the US, the Northwell system where I work was really hit very hard. And this is a JAMA article describing the early experience of 5,700 patients that were admitted within the Northwell system. And you know, the clinical findings were really very similar to the experience in China with respect to the type of presentation that patients were having. And you know, I think that the stress on our system is the reason why this curve has been shown so many times, because the concept of flattening the curve, really more than anything else, was put into place as a concept because of the need to really preserve the ability of our healthcare systems to deliver the care that needed to be delivered. I think all hospitals within our region, all of which you are familiar with and are part of, really flexed up considerably, increasing the number of beds, creating units in areas of the hospital that really would never have been considered, like our large conference rooms. The chairs were ripped out and beds were put in. All of the recovery areas were converted into intensive care units. Tents were put up, and I'll show some images of that. But just in terms of the personal protective equipment, the daily burn rate was staggering. And if you just really look at the N95 masks, that there were on a daily basis as much as 25,000 N95 masks that were being used each day at its peak. And that compares to about 15,000 for the whole month, the month before. So it was a tremendous burden that was placed on the system. And one of the things that I was heavily involved with was this concept that we kept hearing of redeployment. And fortunately, we're now in a stage of what we are calling repatriation, but really the concept of redeployment, and I know that many of you are well familiar with this because many of you, I suspect, have been redeployed, is the idea of people becoming what we call COVIDists, as opposed to hospitalists, but they are doctors working within the hospital, really following protocols to take care of these very sick patients. And it was taking patients that were typically working on inpatient hospital services like our hospitalists, many times moving them into the intensive care units, and then backfilling their roles with other doctors. And so what does that mean? It means backfilling with urologists, backfilling with neurologists, backfilling with fellows that were doing subspecialty training in other areas. These were the people serving as our medical doctors, of course, in addition to our hospitalists. And this redeployment went on for probably 6 to 8 weeks as we were approaching our peaking, plateauing, and then coming down. And this is one of the tents that was put up on the Northwell campus to handle some of the overflow that we needed to manage. So let me shift back into talking about some of the clinical timing. So patients can be exposed, and then generally the patients can become symptomatic anywhere between around 2 days to 14 days, 14 days really being very, very long, usually between 2 to 7 days after their exposure. Generally asymptomatic for the first several days, and then patients developed, if they did develop symptoms, fevers, dry cough, fatigue, anorexia, loss of taste and smell, and occasionally GI symptoms. So this is a slide that shows it a little bit differently, and you can think about it in a couple of different stages. And the patients that developed what we would say just the viral response phase was the early phase of illness. And those patients had symptoms for anywhere between 5 to 7 days. The majority of those patients recovered and recovered at home. And that was a lot of the messaging at the early stage of the pandemic, was that if you're not sick enough to come to the hospital, you should remain home because the majority of you are going to get better. And that is what happened with the majority of people. Unfortunately, there's a group of individuals, and not easy to identify them when they first become sick, that got very sick with not only pulmonary phase and developing bilateral pneumonias, almost always bilateral, but also a group that then progressed from there having a very intense hyperinflammation phase. And these are the individuals that became very sick with ARDS, acute kidney injury, multisystem organ failure, cardiac failure, and really managed in the intensive care unit. At this point in time, because of our availability of remdesivir in certain situations, we believe that antivirals have a role in the early stage of illness, but in the later stage, probably less of a role. And in the later stages, we were using both in clinical trials as well as in off-label use medications like tocilizumab and other IL-6 inhibitors, as well as IL-1 inhibitors like anakinra, and in some cases corticosteroids, although that fell out of favor. And I'll get into a little bit of that. But the idea in this later stage was the need, or at least the perceived need, to control the hyperimmune response. There have also been some interesting other manifestations that we're seeing. I think many of you have heard of this COVID toe, which most closely mimics chilblains, which, but basically these kind of bluish, purplish patches on the dorsum of the toes and our fingers. And, you know, this was described in many individuals that had COVID and was, you know, an interesting extrapulmonary manifestation of the illness. In terms of diagnosing our patients and where the greatest amount of virus was, this was a virus that predominantly was in the nares. So doing a nasopharyngeal swab was the best bet as opposed to a throat swab. Although as the illness progressed, it localized more in the lungs, and a sputum sample would often be a better place to get a diagnosis in people who had been symptomatic for a very long time. This is a slide that was published early on, and this is from experience in China. And the only thing I just want to point out here is that there was, in the hospital room of patients in this small report, evidence of abundant environmental contamination. Now, I'll just point out that just because you're finding genetic material on surfaces does not mean that this is viable virus that is able to actually infect another individual. But certainly until we know more, it does support the idea of environmental cleaning, continuously attending to high-touch surfaces, washing hands, and refraining from bringing our hands to our face. And I think that that's something that should be continued to be adhered to. This is an example. This is a slice through a CAT scan of the chest. And again, these were just one after another. And, you know, there was a point that scans of the chest just kind of stopped because they weren't really altering the management as we were in the middle of our peak. The exception is that this is an illness heavily associated with venous thromboembolic disease as well as arterial thrombotic disease. And so while we stopped doing CT scans of the chest without contrast to look at the lung parenchyma, there were many patients that had CT angiograms looking for pulmonary emboli, and of course we would see the lung parenchyma as part of that. I want to shift for a little bit into this just concept of immunity, and that'll lead us into a little bit about the antibodies and testing, and then we'll go back into some of the diagnostic testing. But just a background about immunity to viruses in general. So immunity is quite complex to viruses. There generally is some combination of humoral and cell-mediated immunity that is necessary to control viruses. And then, you know, you can have virus antibody made, but not all illnesses are neutralized by the production of antibodies. So for example, in measles, antibodies are protective, and the same for rubella. But for HIV and CMV, although there is an immunologic response with the production of antibodies, they're not protective. And that's for a number of reasons, in part because in the case of HIV, there's frequent mutations that occur, and so antibodies are produced, but they're not neutralizing and protective. You know, antibodies generally are produced in a fairly complicated way after antigens are presented to the immune system, and then there is antibody production. A normal response in general is initially to have an IgM response, followed by an IgG response, and then this is typical of what we see with COVID serologies, where there is an IgM, although the Northwell Labs is also looking at IgA as a marker for early exposure, and then eventually an IgG. So we do believe that the antibodies produced as a result of infection with COVID, we believe that those antibodies will be neutralizing and protective, but we don't know, and we won't know that for some time. I think if it's similar to other respiratory viruses where we do not see individuals becoming infected within the same season of having a viral infection, so you get you know, influenza A once, doesn't mean you can't get influenza A and influenza B, but you get influenza A once and you can be exposed again and again, but you're generally not going to get influenza A again. And the same with the community coronaviruses that we have seen in the last several years, the same with RSV and metapneumovirus and metapneumovirus and other respiratory viruses that we commonly see. It's not common to have recurrence of these viruses. And we would believe that at least within the same season, that the same should hold true for COVID. Parainfluenza was what I needed to get from the back of my brain. So again, it's premature to conclude that a positive serology indicates long-lasting immunity. One of the values of doing all of this antibody testing is that you know, on the one hand, we're not certain. On the other hand, it probably does provide some reassurance to healthcare workers, but at least in the short term, it's not going to change how we make decisions, at least not right now, how we deploy healthcare workers. But it's very helpful, I think, to understanding the epidemiology of this illness within our local community and within the larger community. And I think it does have impact in larger scale planning as our country starts to open up again. I want to shift back now to the diagnostic testing for COVID-19, which has in most centers been a nasopharyngeal swab. Initially, it was 2 swabs, 1 from each nostril. That rapidly changed to a single swab. And it changed for many reasons, but one of the big reasons was the supply chain issue, where there was really a very deep concern for our ability to maintain a sufficient amount of just about everything in the hospital. Just about everything, including viral media, including swabs, including our ability to do testing on multiple specimens. So it changed very quickly to doing 1 single swab. It's a PCR, and depending upon the instrument used, the results could come back in 4 hours, or in the early stages of this, which I think really set us back significantly. It could take 2 to 3 days for results to come back. There are false negatives, and we were faced early on and continue to be faced with situations where we have a very high clinical suspicion and a patient has a negative result. And I'll get into this in a little bit, but the recommendation in those situations was to repeat testing. And I'll show a slide that describes that. This is a slide from the New York City Department of Health that really, I think, is transformative in terms of how it compares to the recommendation, let's say March 10th, where March 10th, the recommendation was only to do testing if somebody had recently traveled to an area such as Wuhan or certain parts of Italy or Korea or other parts of the world where disease was endemic at the time, and to only do it if a standard respiratory panel was excluding any other respiratory illnesses. It's totally changed. And now testing is recommended almost, I would say, as much as you can do it. Test as many people as you can. But this really kind of codifies their general recommendation from the New York City Department of Health, and that testing is now recommended for, of course, people who are symptomatic, but also for close contacts of a person with confirmed COVID. And that's a difference from where we were initially, as well as residential, the staff of places like nursing homes, shelters, or adult care facilities. In fact, you may have seen that for staff that work in a nursing home in New York, there's the requirement that they get tested now twice a week. And that's because of the significant outbreaks that have occurred in nursing home and trying to protect that population. This is a slide from the Infectious Disease Society of America regarding testing. Again, symptomatic individuals, of course, get testing. In terms of the asymptomatic group, we're testing anybody who's going to undergo an immunosuppressive procedure, so chemotherapy or, of course, transplant, time-sensitive surgeries, or if they're going to undergo any aerosolizing procedure. In terms of what you're seeing on the left part of this slide is that if you get a test and it's negative, you can stop there only if you don't have a high clinical suspicion. But like any test and any clinical condition, if there remains a high clinical suspicion, the recommendation is to repeat the test. I'll tell you that at North Shore Hospital and at LIJ Medical Center, every single patient that comes into the hospital, regardless of the reason they're entering the hospital, is getting a COVID test. And on both campuses, those individuals who are negative when they come in, if they remain in the hospital for beyond 7 days, they are getting tested every 7 days to focus on any nosocomial spread of the virus, which we did see some of at the peak of COVID. And we are trying incredibly hard to mitigate any further nosocomial spread. And I think that we are very much on top of that at this point. This was an algorithm that we really created very early on, recognizing that on the one hand, we needed to do repeat testing on patients for which there was a high clinical suspicion, but that if we retested everybody, we were not going to be in a situation that was sustainable because of the supply chain issues that I mentioned earlier. Just could not, first of all, we couldn't get tests back quickly enough to even allow for 2 samples. It would take sometimes 2 to 3 days to get the results of 1 sample. To send a second sample probably take 5 to 6 days in total in some situations early on. And we just couldn't keep up with it. So we developed a clinical algorithm where we said if a patient had respiratory symptoms, fever, and a lack of an alternative diagnosis, that if they were still symptomatic, they should get tested again if they either had known significant direct contact with somebody with COVID, or if they had radiographic imaging showing bilateral infiltrates. And that's where the value, more than anything else, of these CAT scans really came in, is that they were showing this bilateral ground glass, and we had a lack of a clear alternative diagnosis. And even though a negative swab may have occurred, we would repeat the swab and very often see a positive result the second time through. This is a slide that I took this image from JAMA recently. And I don't want you to get too lost when you take a look at this, but focus on a couple of things, and I'll walk through it for a moment. In the blue is the Nasopharyngeal Swab Pcr, so that's the standard test that I just described. That result will be positive early, even before symptoms develop, but can remain positive for a very long time in some of our patients. And when I say very long time, I mean 6 to 8 weeks out. It is now believed that those individuals who are 6 to 8 weeks out and have positive tests, that it is not viable virus, meaning that we can't culture that virus, and it's highly unlikely that it is infectious. But patients remain positive for quite a long time. So just by virtue of getting a positive result does not mean that that person has active COVID infection, but it can be a real struggle to understand the situation. When you look at the the sort of pinkish, purplish line, you can see that's from a bronchoalveolar lavage or sputum PCR. So as time goes on, the virus moves from the nasopharynx into the lungs, and even in the non-symptomatic individuals, and you're more likely to get a positive result later on in those people. So if you have somebody who you really think had COVID 5 weeks ago because of some condition that they now have, and the initial nasopharyngeal swab is negative, you can do a sputum sample or potentially a bronch lavage and very more commonly see a positive result. And then you can see the serologies, which are the dashed results, which you see appear later. IgM and IgG actually appear roughly at the same time, IgM a little bit earlier, and then hopefully the IgG will be long lasting and protective, but again, time will only tell. This is a fairly busy slide, and I only want you to really understand one thing about this, is that we had clinical trials for remdesivir, which is an antiviral medication, and we also had clinical trials in place for cerulumab, which is an IL-6 blocker. These are the clinical trials really focused on two different ends of the illness. The remdesivir as an antiviral worked on the viral replication, and that again is felt to work better in the early stages of illness, whereas the cerulumab is used in patients that seem to have this hyperinflammatory illness in an attempt to try to quell the inflammation, although the clinical trials really did not prove it to be beneficial. It is still felt that in a subgroup of patients that it does have benefit. So remdesivir really was the agent that emerged in the last month or so and is now approved for emergency availability. We have it in some of the main centers within the Northwell system, and I know that it's more widely available outside as well. And so what are some of the results? I mean, the results are not dramatic of the benefit of remdesivir, though it did show that patients had faster time to recovery compared to placebo. Median time to recovery was 11 days for patients treated with remdesivir compared with 15 who received placebo, and also a very minimal survival benefit. But if you look at the p-value, it's not really dramatic. So this is a good drug, probably provides benefits. Certainly the earlier that patients get it, the better. But where this falls and how we use this going forward is hard to know. Relatively safe medication. Contraindications to use are creatinine clearance less than 30 and severe LFT abnormalities. In our center, we're prioritizing the use for patients that were diagnosed within the most recent 7 days as a category 1 and 14 days in a category 2. We have had enough drug to treat our category 1 and 2 patients. Our category 3 patients are those that we have had illness for beyond 14 days or who have been on ventilators for beyond 14 days. We don't think that there's a significant benefit for remdesivir for those individuals, and we've not prioritized its use for them. Convalescent plasma got a lot of attention, really based upon very small case series. We have clinical trials occurring actively and ongoing at a few different Northwell sites. And we also had clinical trials with the use of hydroxychloroquine and high-dose famotidine. I won't get into that too much except to say that there was suggestion that the high-dose famotidine, and I'm talking 120 milligrams 3 times a day, had an antivirologic effect in a safe way. This was our most recent treatment algorithm, and I would say that we went through about a dozen of these and refined this on you know, almost a daily basis some weeks, and a little bit less frequent after that. But there are drugs that used to appear on here, like hydroxychloroquine, which were removed or put in a box here that you could see in the bottom of the right, where we stopped recommending it, in fact, recommended against it. A lot of patients also were receiving corticosteroids, and we took to trying to really quell the use of corticosteroids, and really recommending that steroids is unproven and with potential harm, causing prolonged viral clearance, and also pointed out that IDSA suggested against its use simply for COVID pneumonia, and that corticosteroids and ARDS due to COVID had not been studied, and really its use was recommended only in clinical trials. We tried when possible to steer our patients toward clinical trials, which I think was an important thing to do in the setting of not having a clear-cut winner for how to best treat this condition. And I think that we stood up many different clinical trials and really tried to steer patients into one of those clinical trials when it was possible. But really, for the most part, it really was supportive care, and supportive care and refining that. So what I mean by that is giving oxygen, but not giving too much oxygen, giving it so that the oxygen can allow patients to be in a range of 92 to 96% and no higher than that, because of the potential for oxygen toxicity that could occur. There was a lot of work done, and when I sort of personalize this and say there was a lot of work done, I know very well that the work that I'm describing has been done in every hospital in Nassau County, and not just within the Northwell system, but I'm just sort of giving my personal reflection on things. But a lot of infection control precautions were put into place. As you all know, elective surgery was canceled. Mask mandates were put into place very early on, and testing now for any surgeries for all patients is performed within 48 hours of the procedure. There was a absolute restriction with visitation, though there's a pilot, as many of you know, at a few hospitals in New York State, including Huntington, Plainview, I think Lenox Hill, and I think there's a couple of others that are piloting, allowing visitors in a very controlled fashion back into the hospital. They need to be wearing PPEs, and the time with which they're allowed to be in is limited. I want to talk a little bit about contact tracing, because I think this is going to really be something that many of you have already heard about, but this is going to continue for the next several months and potentially the next several years. We did not have a sufficient public health force to handle this illness at its early stages. So you can consider a condition like tuberculosis or syphilis or other sexually transmitted infections that you have a diagnosis that the Department of Health learns about, and the Department of Health then has a force of contact tracers who will contact individuals who may have been exposed and either get them into testing or treatment. And you can do that because you have a certain number of contact tracers to handle that. Very different with this illness because of the explosion in the number of cases, and just from a number standpoint, the inability to track this. The reason, again, for this idea of flattening the curve is that we need to have a manageable number of patients that have this illness in order to manage it. We can't ever get into the situation we were in at the end of March through the end of April, where the numbers were so high that our hospital system was completely stressed. People that needed to have elective surgeries were not getting it. And from a public health perspective, there's no way to manage it. But now that where numbers are lower, I think we can, and there'll be contact tracers that will be identifying patients that are testing positive and tracing their contacts, quarantining, testing those individuals, and going on from there. I think until, again, there's a vaccine and this is really definitively controlled, this is the essential work that is going to need to continue. And the hallmarks are identifying all cases, isolating infected patients, quarantining the contacts, and that's going to include healthcare workers. And I think that we have the potential to really lose more healthcare workers in the coming months to quarantine than we did in the first month or two, because if you remember, it became clear that if we didn't do something about it, that we were going to lose healthcare workers to quarantine very, very quickly. So the Department of Health said, well, okay, you're not going to be able to take all these healthcare workers away. So if they were exposed, you'll have them wear a mask, they'll monitor themselves, and if they become symptomatic, then they'll step out of work, but not until then. And that's what most healthcare systems adopted, especially those that were inundated, like the ones in Nassau and Suffolk and New York City. All right, so let me shift over now to just give a little bit of numbers. I think this is from New York City Department of Health. And again, cases significantly down, hospitalizations down, death fortunately down. So good news there. This is from the Northwell system. The numbers, we had well over 3,000 patients hospitalized at its peak. Earlier this week, we fell below 1,000 patients, and each day the numbers continue to come down. The challenge that we continue to have is the course in the intensive care unit continues to be very, very long. And these patients remain on ventilators for a very long time. And so the percentage of our patients that are COVID positive that remain on ventilators has crept up, because some patients that just never made it to the intensive care unit stabilized sufficiently to be discharged, whereas our intensive care unit patients remained. A lot of other news that has been reported, and our nephrology group at Northwell reported on the fact that acute kidney injury was extraordinarily common in patients admitted to the hospital. So if you take it, all patients admitted to the hospital, about a third of those patients developed acute kidney injury, with 10 to 15% requiring hemodialysis. So that's a really, big hit to an area of the body that, we think of this virus as being a respiratory illness, but caused enough sepsis-like illness and systemic symptoms that the kidneys were really hit hard as well. A lot of neurologic symptoms that were part of this. I showed you the COVID toe. Clotting was a big factor, and we saw there was an early autopsy series that we saw within our own health system that showed patients with significant thromboembolic disease, even those patients that were on standard DVT prophylaxis when they entered into the hospital. So the strategies for dealing with that really evolved, and everybody was on DVT prophylaxis with low molecular weight heparin or other agents, and at fairly high doses for those patients in the intensive care units that were at greater risk. And I think we've all heard about the recent childhood inflammatory syndrome that appears to be a post-viral syndrome, akin to the way some other viruses interact with children. One of the other challenges that we are faced with more and more now is how to discontinue isolation. There's two main strategies. There is a test-based strategy, which relies upon having a clinical improvement and also having 2 negative PCR swabs separated by 24 hours. An alternative strategy is a symptom-based strategy where if you have 72 hours of no fevers and an overall improvement of symptoms, and the patient has 10 days passed since symptoms first appeared, then they can also come out of isolation or quarantine. This is mostly for our homebound patients. For our hospitalized patients, it is preferred to use a test-based strategy and for 14 days. So, well, actually it's for an extended symptom-based strategy where instead of 10 days, it's 14 days, or to use the test-based strategy, which is felt to be a bit more reliable. Our nursing homes are requiring negative tests before they accept patients back into the nursing home. Also prolonged isolation, 14 days minimum for our immunocompromised population. Let me skip this and just point out a couple of other things. This is just taken earlier in this week from the New York Times, which actually has been a phenomenal resource during all of this, as good as most any other medical journal. You can see all the areas where cases are decreasing. Fortunately, cases continue to decrease in the New York and New Jersey area. We'll see. This is also from the same day in the New York Times, as several more states will move toward reopening and areas within our own state will start to reopen. We're going to have to keep a very close eye on things. We're going to have to really rely upon social distancing, and we're going to have to rely upon these contact tracers and getting more and more testing done. We really want people to get tested. I want to just urge that more and more, that is going to be the key to mitigating this as we move through this recovery phase and we move into the fall. And I think one of the things that really concerns us is that we could be dealing with simultaneous influenza and coronavirus in the fall. And that's something that is going to be a real challenge. And again, as I mentioned earlier on, it's something that we didn't have to deal with quite as much this time. Also, as this illness evolves, where I showed you earlier on that big giant red right over the New York region, as time goes on, this is likely going to be an illness that causes the most damage in parts of the country that are most affected by high blood pressure and diabetes and obesity. And you can see the southeastern part of the United States, which is really stricken the most significantly by all of the things that interact with social determinants of health, and where there's a high prevalence of those conditions. Those tend to be markers, as well as socioeconomic status of outcomes with this condition. There's something called the R0, which many of you may have heard of, and basically too much into it. Then R0 is for every individual that has an infection, how many people will that individual the infection onto? So when the R0 greater than 1, that means that the illness will be passed on and continue to grow in the community. When the R0 falls below 1, which it is right now in the New York area, the number of cases is expected to decline. And this is from actually kind of an interesting site called rt.live that I've been following to look at the R0 in the New York region. And fortunately, it's right at around 0.85, now a little bit lower than that, and that it correlates with our ongoing drop in cases. So just 2 more slides, I think. Again, the length of this outbreak is still not clear. Vaccine development is going to be the main thing that changes it. Asymptomatic spread, we know, is common, and airborne spread, we believe, is also occurring, but not nearly as much of a concern as direct contact droplet spread. But because of that, it's still important in our communities to have us be socially distancing. I can tell you that within our own health system, for all patients, we're using N95 masks, and I don't think that's going to change soon. And I fully intend personally, at least in my role as an infectious disease clinician, to continue to wear N95 masks throughout patients that I see, and I mean non-COVID infected individuals. Few think that COVID is going to disappear in the summer, though it is expected that it's going to significantly decline. Hopefully we'll be at very, very, very low levels, and then we'll, of course, see what the fall will bring. And I guess wanted to leave with this, which I thought was somewhat optimistic. And this is the article in the Times from earlier in the week that showed some promise, though very, very small numbers, of this company, Moderna, as well as many other companies that are really in this foot race to develop a vaccine, which again will change things dramatically. So I will stop there and happy to answer any questions.
Good.
Ready for questions?
Yes.
Yeah, David, it's David Podwell. Thank you for a great talk. The key obviously for treatment is testing in terms of public health. Can you comment on some of the tests, that places are going to use, camps, people going back to work? You have RNA lab-based genetic testing, and then more of these rapid onset antigen testings, and the different type of testings and the pros and cons as we start thinking and moving forward on that. There's a lot of constantly hearing all these new companies coming out with different testing, Abbott, Quintel, testing kits or procedures, but it seems to be in two buckets, these RNA lab-based genetic testing and the antigen testing. Can you comment on that? Because it's a little confusing.
Yeah, and also I'll say that even before we get into the different types of tests, that there's also the ability to do not only nasopharyngeal swabs, but now you can do a nasal swab, you can do a saliva test where you basically spit into a cup. And so I think that all of these tests, all of the types are going to continue to increase. And I think, you pointed out the difference between the actual molecular test, the PCR technology test, and the antigen testing. The antigen testing is not quite as sensitive, but it's kind of like a rapid strep test where you do the test, you get the result in 15 minutes. And yes, I can envision having situations that, for example, schools, colleges, a restaurant. I mean, I had this conversation with somebody about, well, you go into a restaurant, they bring you into an area where you can have a cocktail, stay socially distanced, you do an antigen test, and if your test is negative, they show you to your table. And, I think that some of that could, whether it actually happens to that degree or not, but that concept, I think, may be something that lives with us for a while. The antigen test is going to be something that's going to come out and is going to be far more prevalent, and we're going to be able to get the results very quickly from that. I think that there's, in order for, I know that a lot of discussion is around opening schools, opening colleges, in order for these places to open up and for people to feel like it could be successful and stay safe and that you can have classes together. You're going to have to test kids when they get on campus, and you're going to have to test them at some interval of time. And I don't know how frequent it's going to be, but in the same way that we're testing our asymptomatic patients that are negative when they are in the hospital, people are going to have to get tested to some frequency, especially in college campuses that, are going to take some steps to separate and reduce crowding and things like that, but they're going to have to do testing as well.
Dr. Hirschwork, can you see the question and answer tab at the top? Q&A.
I saw, what is currently your biggest concern as a healthcare professional?
Well, no, the Q&A, not the poll. The Q&A is right next to it. Do you see that?
Yeah.
So there's some questions there for you.
Okay, so knowing that patients may stay PCR positive for 6 weeks with non-viable virus, how would you manage the recovering patients if their 14-day PCR or later remains positive? Yeah, so I think that you know, it's a really good point, and we're struggling with that, and it gets to this concept of whether we use a test-based strategy. And I am predicting that out of the hospital, we're going to rely much, much more on a symptom-based strategy where if you're 10 days out, we don't do any more testing. And even in the hospital, we're doing less of this as well. We're seeing situations where people are positive for 2. We're going to start to have to ignore that and rely upon a symptom-based strategy for those individuals. So I hope that answers that question. Scott Brown, have you seen any worsening of symptoms with patients who have sickle cell disease? You know, there's a couple of groups of patients that we really expected to see challenging outcomes, including our HIV population, our immunocompromised population, and our sickle cell population. And we really did not see that in that population. So, you know, we saw patients with HIV admitted. They tended to have very similar outcomes. We saw solid organ transplant patients, very similar outcomes to our general population, and the same for our sickle cell population. In terms of other factors beyond flu that may or may not contribute to the second wave, I think, you know, part of it is the degree to which we relax on our social distancing. And I think it's clear that, you know, that there's the feeling of many in our communities that, you know, there's the need to, at least to some degree, get back in some form to typical operations. And I think some of that is going to naturally contribute. I think there's going to be an increased mobility, increased transportation. I guess I'm not convinced, unless things get really bad, that we're ever going to be in the same kind of lockdown. And I do think the lockdown was extremely important and effective. But assuming that we are not at that point and that we have mobility in our community, I think that's going to be something that contributes to an increased wave. Let me move on to the next question with the N95s. Is it acceptable to wear? Okay, yeah, for the N95 masks, first of all, there's no real shelf life on them. You can actually inspect them and use them as long as you need. You can use them for a long time. The thing that's going to become problematic with them is the rubber bands are going to snap at some point. So keep them in a keep them in a bag so that it doesn't get too dried out. There's no problem with moving from patient to patient. We recommend using a surgical mask over the N95, and that's what we've been doing in the hospital. And you know, the N95 mask that I have, I've used for several days. And so long as it doesn't get contaminated by an aerosolization procedure, you can continue to use it. And then the question from Susan Wasserman, can you discuss what we need to do to safely open up an ambulatory, to open up in a non-COVID office? Do we need to test employees? Do we need to front desk? Yeah, so, you know, there's an ambulatory, I could only speak for our own system. There's an ambulatory strategy in place where patient-facing staff are going to have N95 masks. They're not going to be tested, but staff will be screened. And of course, if there's an exposure and they need to be quarantined, then they need to be quarantined. But there's not the intention to do testing on staff, at least at this point. So I hope that answers your question. Let's see. I'm sorry, I didn't realize there were more. So, yeah, the concerning things that you're describing in Birmingham and Dallas and Houston. So I showed that one slide where there are the cases are decreasing in several states, but they're increasing in other states. And yeah, I mean, these are concerns. And I did not see the NBC News tonight, but yeah, I think that is all very concerning. The antibody accuracy testing. So there is a lot around which antibody tests are reliable, which are not. I don't quite know all of which are reliable and which are not, except to say that the test that is offered at Northwell has been validated. and is felt to be highly reliable. I'm sure the same exists among other testing outfitters, but I just don't know the details, but I can speak for the reliability of the one at Northwell. I did gloss over steroid use, Dr. Schreiber. So, okay, I want to talk, I'll give you our approach to corticosteroids, because there was a lot of discussion and debate about this. Steroids were used a lot at North Shore and LIJ in the early period. And so here's how we really, and this was a collaborative effort to put this together by infectious disease and pulmonary, at least within Northwell. But that corticosteroids we felt could be used in situations where patients were developing ARDS with COVID, and that they shouldn't be used in other situations. Part of that was adapted from data to show that for the initial SARS, that it prolonged viral clearance, that for other viral illnesses, that the data had not been strong, that it also was concerning for increasing the risk of bloodstream infections that we were starting to see in some of our patients, and the fact that the Infectious Disease Society of America put out recommendations to not use it except in the setting of a clinical trial and except in the setting of the treatment of ARDS associated with COVID. And that's eventually what we evolved to starting to do. I think that there'll be a lot of studies that are going to report out on this in the coming weeks and months, and that will better define the use of corticosteroids if we see a second surge in the fall. But right now it was clear on our algorithm that we did not recommend the use of steroids. And I can tell you that I had reviewed from many other large medical centers around the country really did very much the same, where there was a lot of steroid use initially and then very little as the pandemic went on. Mitch Berger, some patients complain of persistent symptoms for several weeks, even after they seem to have recovered. Headaches, pleuritic pain. Yeah, the thrombotic events tend to be late events, and we've seen people recover, go home, and then come back with pulmonary emboli. So yes, that's something that that has been seen. And I think that the recovery has been very, very challenging for a lot of our patients. And I continue to get phone calls from patients that I take care of in the office saying, I mean, it's been 6 weeks and, you know, you told me I was going to feel better, and they do feel a little bit better. But I think that we're seeing a lot of examples of very protracted recoveries. And I think there's going to need to be a lot of work and study on this. And I think that pulmonologists are going to be dealing with this for quite some time because we don't know what the long-term effects for many of these patients are, if they're going to have degrees of chronic lung disease. And, you know, because this illness has only been out there since December in the world, I don't think we know the answers to this. So time is going to tell. The final question, at least that I see, is some patients, patients positive or negative for COVID antibodies but complain of excessive fatigue. Oh, the EBV. There's not any cross-reactivity that I am familiar with. I'm sorry. In a patient who's on steroids, are there any precautions, any increase of risk of COVID severity with steroids? Yeah, not that we've really seen. And I know that there have been some reports. I can't remember the exact report. This was a report that came out of Mount Sinai and was put in New England Journal of Medicine about a month and a half ago. And they looked at their immunocompromised population, though those individuals receiving biologic agents for inflammatory bowel disease and some rheumatologic illnesses. And as best I remember, they did not report worsened outcomes with that group. So I think I've answered all the questions at this point.
I think that's I think that's it. Does anybody else have any other questions? Dr. Moody, Dr. Podwell, anything else to add? I guess not. Okay, well.
David, thank you very much for taking the time.
You're welcome. I know it was a lot, and I hope that it was helpful. I know that there's just been a ton of stuff out there now. So anyhow, I hope this was helpful to people.
I guess my only question now would be what in terms of a second wave or.
I'm sorry, I didn't hear so well that question.
What's your vision for the future in terms of a second wave?
Yeah, you know, I don't think that we're gonna ever get into a situation where we're gonna have as many patients with COVID in the hospital as we had in early April, at least in our area. That's, I mean, I don't think that that's gonna happen. But again, what concerns me very much is, you know, will we close surgery? Will we do all of the things that we did the first time through? And if not, what will it look like with a moderate amount of COVID? And you know, this was a pretty bad influenza season as well. It seems like forever ago, but think about how busy our emergency rooms were with, you know, I could speak for North Shore and LIJ with, you know, 50, 60 patients waiting for beds for hours and hours. And I think that the hospitals are committed to not ever allowing something like that to happen again. I don't know quite how that gets mitigated, except to say that we may need to have more surge areas just remain in place to allow for that, because we just can't be in a situation where we have patients one on top of the other waiting for beds upstairs in the hospital. I guess my biggest concern is, what does it look like when we have both COVID and influenza? But I think that in terms of the raw numbers for COVID, you know, I don't think that we'll see that again.
Anybody
All
else? Right. Thank you, everybody, for participating. Dr. Hirschwork, thank you so much.
Okay, have a good night, everybody. Thank you.
You too.
Thank you. Good night.